Patient Safety Research Collaboration SafetyNet seminar. And I'm really delighted today to welcome Luke Budworth and Emily Parker, two people who either currently or have worked in our team in Yorkshire and Humber before, and they're going to talk to us today. It's going to be an unusual seminar for us because it's not just one person, it's both Luke and Emily talking on the same subject, but from quite different perspectives. So they're going to talk about uncertainty tolerance in emergency medicine, and they're going to take it in turns to do bits of the presentation. So we will be starting with Luke, who will introduce the concept of uncertainty tolerance and why it matters in clinical practice. And then Emily will share some insights from a scoping review and interview study that focus on the emergency department context and factors that influence uncertainty. And then Luke will come back in to present some findings from a recent study conducted actually across 5 emergency departments in Yorkshire. And we'll conclude with Emily discussing potential interventions to support ED doctors tolerate uncertainty. So quite a lot of content to get through. I'm going to ask people please to keep their microphones off during the presentations, but please do post any comments or questions in the chat and I'll pick them up at the end, because there will be around 10 minutes at the end for questions. I just do, before we start though, want to briefly introduce Emily and Luke to you. So Emily Parker, or Dr. Emily Parker as I should call her, is a policy officer at the Department of Health and Social Care, but she previously worked as a research fellow in the Yorkshire and Humber Applied Research Collaboration, specifically focusing on improvement science. Emily received her PhD in health psychology from the University of Leeds back in 2024, and uncertainty tolerance was the focus of her PhD. She used mixed methods throughout that and particularly focused her work on the emergency department context. Dr. Luke Budworth is a senior research data analyst at the Yorkshire and Humber NIHR Patient Safety Research Collaboration, and he primarily works in the Rethinking Safety Intelligence for Improvement theme. He leads and supports projects that use large linked healthcare datasets, particularly via the Connected Bradford dataset. And he uses these datasets to understand and develop tools for addressing patient safety challenges. His expertise very definitely lies in statistical modelling, health data science and applied analytics. Luke holds an MSc and a PhD in health psychology from the University of Leeds and an MSc in health data analytics from University College London. So after those introductions, and without further ado, Rebecca Lawton, and I'm the Director of the Yorkshire and Humber Patient Safety Research Collaboration, would very much like to welcome Luke and Emily to deliver their seminar. Thank you so much.
Thanks, Rebecca, and good afternoon, everyone. So I am indeed Luke Budworth. I am indeed a Senior Research Data Analyst at the PSRC. The work that I'll outline today that I led on uncertainty tolerance was when I was a research fellow in the Applied Research Collaboration, and that work was over the COVID period. Yeah, but before I talk about that, I'll just say I do feel like a slight imposter, because I wouldn't say I'm an expert in the quite vast field of clinical decision making, but I am happy to say that Emily definitely is. So after you've suffered through me, I'm sure you'll enjoy Emily's insights from her PhD. So before we talk about some of the research, I thought I'd give a bit of a background as to, you know, what uncertainty tolerance is, how we might measure it, and how the degree to which a clinician, a doctor, can tolerate uncertainty, the degree to which that may have impacts on real world outcomes. And I'm going to have to do the COVID thing of asking for the slide to be moved every time. Brilliant. Thanks, Emily. So Yeah, background. So every decision we make is made. So if we go back one, sorry, thank you. Every decision we make is obviously made with some degree of uncertainty because we never know the future with certainty. We're not omniscient. Sometimes we make fast, intuitive decisions, quick judgments based on pattern recognition, heuristics, or experience. Other times when, say, stakes are high, or the risks are unclear, or information incomplete, we slow down and think more deliberately. Our ability to tolerate that uncertainty, to hold it, to sit with it, and still act, has shown to vary between individuals. And that's obviously what we're exploring in this work. Next slide, please. So here's an analogy, a bit of a strained one. Let's say you've got a choice between taking a bus, which is typically unreliable, or taking a car, which is more predictable. So you're either heading to a low stakes event. So for instance, a friend's dog's birthday party. You may catch the buzz in that case, because worst case scenario, you're a bit late and they're annoyed, and that's not really a big deal. But say you're heading to something more important, like a friend's wedding, you're possibly more likely to take the car. Same choice, different stakes, different tolerance for the risk. Now, yeah, next slide, please. Now imagine someone with very high uncertainty tolerance. They may take the buzz even when it's the wedding because they're more comfortable with the possibility of delay, or perhaps simply less bothered by the consequences of being late. This is obviously a metaphor for clinical decision making. A more uncertainty tolerant doctor might accept the chance they're wrong on something and delay action. A less tolerant one may act early just in case. It's important to say tolerance isn't good or bad by itself. It depends on the context. Next slide, please. So here's the distinction in simple terms. High uncertainty tolerance in an individual, they may accept ambiguity, stay flexible, wait for more clarity. Someone with low uncertainty tolerance may find ambiguity aversive, so they might act quickly to gain control or closure, sometimes defensively. And these different styles, different psychological styles, might affect everything from, say, test ordering or referral patterns in a doctor. Slide, please. Sorry, next. Yeah, thanks. Oh, yeah. And I think it's worth quickly distinguishing the difference between uncertainty tolerance and risk tolerance, because they are quite related, overlapping concepts. So I'd say uncertainty tolerance is about functioning when things are ambiguous or unclear. For example, making a decision with missing data, incomplete patient records, say. Risk tolerance, by contrast, is about accepting known risks. So, say, choosing between two different treatments when side effect rates are known or clear. So both obviously matter in clinical work, but I'd say uncertainty tolerance is arguably sort of harder because it deals with the discomfort of not knowing. Next slide, please. So thanks. How may this impact practice when rubber meets the road? So this is a basic diagnostic grid. Along the side, sorry, the clinician's perception. Do they think a patient, for instance, has a serious disease? Along the top, the actual disease status in that patient. Of course, if their judgment matches reality, that's a correct decision. But when they don't match, you either get false positives or false negatives. Next slide, please. So, yeah, thanks. So let's apply this to, say, a patient attending the emergency department with symptoms of, say, a cancer. If a patient has a cancer and you refer them, great, refer them on. If they don't have cancer, and you, if they don't have cancer, sorry, and you avoid unnecessary referral, also good. But if a cancer-free patient gets referred anyway, that's a false positive. And that's not harmless because, of course, it could cause the patient anxiety. It could, in theory, lead to unnecessary procedures and therefore side effects. And of course, it could incur costs to the system for no real reason, which obviously matters in a universal healthcare system. More seriously, perhaps, if a patient with cancer is deflected, i.e. a false negative, you risk possibly more serious consequences, delayed diagnosis, ultimately poorer outcomes, and potentially litigation. So you could see, consequences of these different decisions. How does UT come into it? Next slide, please. So a doctor with low uncertainty tolerance, on average, might refer patients on more often. So they might try to minimize the risk of missing something. Whereas one with high uncertainty tolerance might be more selective. So they might accept a slightly higher chance of false negatives to avoid overtreatment. So this balance, again, might not just affect patients' outcomes, but also importantly, resource use. So how we allocate resources. Next slide, please. So you could say there's a risk that high uncertainty tolerance may be counterproductive because someone with high uncertainty tolerance might deflect patients more often, and therefore, on average, perhaps patient outcomes might be worse because they miss referring on patients with some sort of serious illness. But when you look at the evidence, the broad evidence actually suggests that uncertainty tolerance for doctors, for clinicians, across different healthcare roles, across different clinical areas, high uncertainty tolerance is actually associated with lower burnout, less stress, and there is some evidence, again, that doctors do indeed use fewer resources, order fewer tests, deliver fewer treatments if their tolerance of uncertainty is high. Next slide, please. And this is a heat map from a large review, which sort of visualizes the strength of evidence of associations of uncertainty tolerance with a range of emotional and behavioral outcomes. Again, uncertainty tolerance is linked to lower burnout, better resilience, improved psychological well-being, fairly consistent effects on clinical behavior. So again, tests ordering, referrals, but also, how doctors involve patients in decision-making. So there's fairly good evidence across different clinical contexts that UT uncertainty tolerance is a good thing. And I'll pass on to Emily now to talk a little bit about uncertainty tolerance in the emergency medicine context, more specifically.
Thank you, Luke. And oh my God, what the... Sorry, these slides are on like catnip or something. They keep they keep going over like loads of slides, so apologies for that. I don't know what's happening. Just bear with us a second while I get this up to date. Sorry. Here we go. Hello, lovely to see you all. Apologies for the technical difficulties. I think my keypad must be broke. So this slide shows the integrative model of uncertainty tolerance from Hillen and colleagues that was developed in 2017 on the right there. So this is the most comprehensive model available of uncertainty tolerance, but it should definitely be seen as a starting point for future research, not a complete...
Emily, the slides are just shifting around all over the place.
Oh.
Yeah, they're just jumping around from one slide to the other.
Oh.
This is the right one now.
This is the right one now, so we might be okay, but they've been jumping backwards and forwards all over the place. Shall we try, and then if not, maybe Sobia could share them?
Yeah, sorry about this. Has it been
stayed
stable
on
for
that
a while?
one now?
Okay, yeah, sorry, I was trying to get it backwards and then, yeah, I think it might have worked now. But yeah, if it does it again, just let us know and I'll stop sharing. Okie dokie. So yeah, this model is related to the review that Luke just discussed there. So it's from the same paper, and it suggests that various moderating factors that range from individual characteristics to more of a social context to organisational context can influence how healthcare staff, but specifically for this presentation, ED doctors, think, feel and behave in response to uncertainty. What it doesn't do is specify what these factors or responses are in the emergency department context, which we're interested in today, which makes useful interventions to enhance uncertainty tolerance difficult to articulate. So my PhD set out 6 main objectives. So we wanted to understand how uncertainty is responded to in the emergency department and what influences this. We wanted to identify both those individual level and organisational level outcomes of the clinical uncertainty and how that uncertainty is tolerated. To think about whether any current interventions actually already enhance uncertainty tolerance, to imply the empirical findings from the studies in my PhD to shape existing theory, and by existing theory I mean this model on the screen, and to establish consensus amongst experts in the topic on what a future interventions for uncertainty tolerance might look like in a UK NHS context. Okay, everyone cross your fingers when I press next slide. Oh, right. Okay. Is it settled? Yeah. Okay. So to address these gaps, I conducted a scoping review and a qualitative interview study using both deductive and inductive analysis guided by the Hillen model. So the reason that I did a scoping review is that previous reviews of this decision-making in this context often focused heavily on clinical reasoning, but without explicit focus on uncertainty. They lacked systematic searches, so there's a lot of literature searches and things. They only considered doctors. The second one there is some reviews require an explicit mention of uncertainty tolerance. So the reason I did a scoping review is because I wanted to include studies that may not have realised they were talking about uncertainty tolerance in the way that Hillen in the way the Hillen model defines it, but they actually were. So if they talked about a kind of cognitive, emotional or behavioural response to uncertainty, they were included. In terms of empirical studies, so they had struggled to deduce the valence, so whether responses were positive or negative from quantitative data alone. And there was a lack of qualitative research in the UK. I also found that quite a lot of studies treated UT as uncertainty tolerance, as a fixed trait rather than considering contextual factors, which I was interested in in terms of interventions for my thesis. So my approach combined deductive content analysis, so mapping the data to the Hillen model definitions, with inductive analysis to identify any new subcategories specific to the emergency department that interventions could focus on. So, for example, where the Hillen model acknowledged situational factors as influencing the perception and responses to uncertainty, they did offer examples, but these were not exhaustive or specific to the emergency department. So if I considered data from the review or from my interview studies to deductively map to situational factors as a category, I would then inductively analyse it to illustrate further subcategories within that. So, for example, time available. Okay, so here I've adapted this was the result of the empirical study. So I've adapted the Hillen model to the emergency department context based on findings from those 2 studies mentioned on the previous slide. So you can see that uncertainty in the emergency department did arise from factors like probability, ambiguity and complexity. There was lots of moderators, such as team dynamics, organisational culture, individual experience, that all shaped how uncertainty was perceived and responded to. And these kind of responses affected outcomes at multiple levels. So there was a doctor wellbeing level, including burnout and job satisfaction. It influenced patient experience and the decisional conflict that patients experienced as well. The way in which doctors responded to uncertainty influenced that. And broader outcomes like the quality and safety of care and patient flow. So this model kind of helps us understand the interplay between those individual team and organisational factors in shaping how uncertainty is managed in the AD. But just thinking about that in slightly more detail. Oh, that's not the right slide. Sorry, just bear with me a second. Sorry, I'm sharing I know why this isn't working now. Apologies. I'm on Google. I think I should have done a PhD in sharing your screen on Zoom, really. There we go. Okay, so yeah, I just wanted to reflect a little bit on how I found looking at this through the lens of the Hillen model. So as I said before, it's widely considered the most comprehensive framework for understanding uncertainty tolerance in healthcare, and it is definitely useful for that. It really helped me to organise uncertainty into three main sources: probability, ambiguity, and complexity, and then look at how people respond cognitively, emotionally, and behaviourally, plus the factors that influence those responses. So that was really good and helpful. But unsurprisingly, real world practice is messier than the model suggests. So one big thing that I struggled with is how it deals with valence. So the idea that a particular response to uncertainty that a doctor has can be classified as positive or negative. So for an example of this that I struggled with was like discussions with specialists and that kind of information seeking. So sometimes that's a really positive behaviour, acknowledging your limits and seeking support for complex cases. But other times it's a way of deferring responsibility. So even deliberately choosing a senior who'll take over the decision. I found that in my studies. So we need to kind of look beyond the behaviour itself and consider the intention and the outcome of it as well to kind of assign a valence. So that was where I struggled a little bit in my PhD. The model also says uncertainty tolerance can be seen as a trait or a state, and my findings did support that. So doctors' tolerance does tend to grow with experience, but context matters hugely. So what I mean by that is senior doctors might generally handle uncertainty better than junior doctors, but on a busy night shift with no safety net in, even their uncertainty tolerance can dwindle as well. So it's shaped by both who you are, your personal experiences, and the situation you're in. And I did find this model really a useful foundation to explore that. The final interesting point that I found is distinguishing responses from outcomes. So you might notice that I've kind of extended the model to the right and below the responses. So thoughts and feelings like confidence and anxiety in response to uncertainty, I've constituted that as part of uncertainty tolerance itself. But decisions like admitting or discharging a patient, I've considered more of a downstream outcome influenced by those thoughts and feelings. So that matters because interventions, I guess, need to target both of those things. So if, for example, we helped doctors reframe uncertainty, say through education that acknowledges risk as part of emergency medicine, we can trigger different behaviours. But on the other hand, promoting positive behaviours like shared decision making could improve cognitive and emotional responses as well. So it's kind of a double-edged arrow visually. So takeaway from that is it was a great starting point as a model. It did need to be adapted for the emergency department context, importantly to acknowledge the complexity of valence. So as I mentioned previously, one of the strengths of this model was its flexibility. So it really allowed me to conceptualize uncertainty tolerance as both trait and a state. So a trait-focused approach looks at individual differences, and a state-focused approach considers how contextual factors like team support or hospital pressures can influence uncertainty tolerance in any moment. So this diagram just shows some sub-themes from my PhD underneath kind of clinical experience as a factor influencing uncertainty tolerance. And it made me explore uncertainty tolerance as a work trait, which kind of overarched all the other themes in the analysis. So this brings together 5 sub-themes: unlearning on the job, accepting the nature of the business, increased use of uncertainty management strategies, the cycle of uncertainty tolerance, and experiencing less uncertainty over time. So I'll just briefly touch on these. So first, unlearning on the job. So many doctors felt that medical training and exams promoted a kind of quest for certainty. They described being taught to seek information and intervene with little to no acknowledgement that uncertainty is often irreducible in this context. So for example, exams will reward selecting the right tests rather than considering when not intervening might benefit the patient. And this was really seen as kind of discouraging patient-centered care and encouraging over-investigation. As doctors gained experience, they started to accept the nature of emergency medicine. So they recognised that risk and uncertainty are persistent and shifted focus from trying to eliminate uncertainty as much as possible to deciding which risks are acceptable. So senior doctors particularly reported tolerating residual uncertainty once serious conditions had been ruled out, while juniors found this harder. So often at the end of an emergency department consultation, once things had been ruled out, they still were struggling with the uncertainty of not having a diagnosis. Experience also led to greater use of uncertainty management strategies. So stronger team relationships promoted higher psychological safety, meaning doctors were more willing to ask for help. More experienced clinicians placed greater trust in patients to return if they needed to. So they felt more confident in kind of safety netting. The cycle of uncertainty tolerance reflects that tolerance didn't increase in a straight line. So there was temporary reductions, even for the more senior doctors that I spoke to. There was temporary reductions in their uncertainty tolerance that they felt were due to transitioning to a more senior role and having more responsibility, or after being on unfamiliar rotations. So sometimes they go out to anaesthetics and then come back. They also talked about this in relation to exposure to an adverse event, prompting more cautious practice for similar cases in the future. So it's not as simple as like more experienced doctors have higher uncertainty tolerance. And finally, I think it's probably important to acknowledge that more senior doctors just do experience less uncertainty over time. They have increased knowledge and confidence, and that reduces ambiguity. So they have more developed pattern recognition through exposure and feedback, test results coming back confirming or conflicting clinical judgment, better familiarity with guidelines and community resources, reduces complexity. So yeah, I just think it's important to acknowledge that on the side of uncertainty tolerance. So I'm now going to hand over to Luke. I'm just going to get this ready there. Oh, it's just did one.
Thanks, Emily.
Thank you. Yeah, Luke's just going to discuss how his study builds on the limitations of the quantitative research in this area.
Yeah, so after all the fantastic nuance and depth, here's a more blunt quantitative angle. So this study, this work, again, was conducted over the COVID period as part of the NIHR ARC with clinical colleagues across 5 different emergency departments, including our own fantastic Brad Wilson at Bradford. Yeah, so I will just give a bit of background to that. Why did we want to focus on emergency medicine? Well, I mentioned that review earlier that looked at associations between uncertainty tolerance and lots of different emotional and behavioral outcomes. Well, it turned out that when you look into that review, look at the individual studies, there really isn't much quantitative research on emergency medicine specifically. This is a huge limitation in my view because, of course, sorry, getting ahead of myself. So yeah, these are the limitations basically from those studies that were found in that review. Emergency medicine studies only looked at one test or treatment typically. They focused on one condition or complaint of patients. All the emergency medicine research on uncertainty tolerance has been based in the USA. I don't think that's particularly useful for us. Of course, the USA has a less resource-constrained system, and maybe there's more defensive practice there because of their litigious society. And all of those emergency medicine, and all of those studies in emergency medicine that looked at the association between uncertainty tolerance and outcomes used a specific scale called the physician's reaction to uncertainty scale. All of them used it to measure uncertainty tolerance. And as the Hillen paper that Emily mentioned suggests, that scale doesn't capture all the different elements which may constitute uncertainty tolerance, i.e. it just might not have construct validity. Next slide, please. So the study aim broadly was to assess one, whether in a UK emergency medicine context, uncertainty tolerance was associated with more positive clinician traits, characteristics, such as lower burnout. Also to assess whether in practice higher doctor uncertainty tolerance was associated with lower costs per episode. So if a doctor with measuring essentially the degree to which higher uncertainty tolerance doctors have lower average episode costs, i.e. order less treatments and so on, but also to assess whether higher uncertainty tolerance was associated with proxies of patient harm. So again, it's speaking to this idea that perhaps a high uncertainty tolerant doctor may make more risky decisions. So next slide, please. Yeah, and worth saying as well, all that is ultimately to assess as an overall aim whether sort of interventions to help modify uncertainty tolerance in practice may be beneficial and not cause patient harm. So we designed and ran a retrospective cohort study across 5 emergency departments. We involved doctors who were ST3 level or above. We thought that they might have more independence in their decision-making processes. The 5 emergency departments were, of course, Airedale, Barnsley, Bradford, Sheffield, and Leeds. We aimed to recruit 50 doctors, 10 per site, and then match 10 patients worth of data to each doctor. Next slide, please. This is a visualization of the study design. So it looks quite complicated, but it's quite straightforward. We essentially recruited doctors and asked them to complete a questionnaire, which had measures. Well, I'll talk about that in a sec. So we asked them to complete a questionnaire, and then what we did was, of those doctors, we looked at the last 10 previous patient encounters where they were the primary treating doctor, and then extracted information about those episodes using a standardized data extraction form. We had a fantastic team of emergency medicine doctors who manually did that extraction for us, and yeah, they're all fantastic. In terms of the eligibility of patients, we focused on patients who had uncertainty-inducing complaints. These were back pain, abdominal pain, chest pain, headache, and vomiting. And we decided on those in sort of an internal survey of emergency medicine doctors. Next slide, please. So we captured in the questionnaire to doctors, captured a wide range of doctor level variables. Again, uncertainty tolerance, of course, burnout, confidence, resilience, job satisfaction, experience of suffering or being involved with a patient safety incident. And we also captured their basic demographics to assess whether perhaps uncertainty tolerance was associated with those. Next slide, please. So maybe a slight bit of repetition, but it bears repeating because this is a fantastic review. I mentioned earlier that a limitation with past research has been the overuse of a particular scale for measuring uncertainty tolerance. Well, this was sort of evidence in this fantastic review by Marie Hillen and colleagues in the Netherlands, where they provided a comprehensive review of how uncertainty tolerance has been theorized across disciplines. In that review, they identified 22 self-report measures of uncertainty tolerance and found that when you look at the items of those measures across questionnaires, they have a large variation in what they measure and how they measure it. They found that existing uncertainty tolerance definitions were kind of vague and inconsistent. So they proposed this model that sort of distinguishes between different sources of uncertainty, people's responses to uncertainty, and moderators of uncertainty, to provide a more holistic picture. And this model is what underpins how we measured uncertainty tolerance in our study, because of course we didn't want to make the same mistake and use the same scale again. Next slide, please. So in the previous slide, I recognize the sort of Yeah, this is just an example from that paper of all the different sources of uncertainty that were identified across those different measures. And you can see how uncertainty is quite a broad concept. Next slide. And these various sources were sort of aggregated up into three main sources. So probabilities, like not knowing if a patient with chest pain will go into cardiac arrest. You know the risks, but it's unpredictable. Ambiguity being, say, an ECG is unclear, or history might be conflicting. You don't know what's true or reliable. Complexity, of course, is someone with, many comorbidities, or perhaps some multi-trauma patient with diabetes and anticoagulants. So everything interacts. The system is hard to grasp as a whole. So yeah, these are sort of the main elements of what determines uncertainty. Next slide, please. And Hillen also, again, didn't just focus on source of uncertainty, but also people's reactions to uncertainty. And they grouped these into three different types: cognitive, emotional, and behavioral. So one person might have more uncertainty, might impact them more cognitively. Another person, it might more emotionally, so anxiety and so on. And one insight from the Hillen model is that, of course, that is not all reactions to uncertainty are negative. Some people are actually, like it, like working in that, find it enjoyable. So one person might respond to an uncertain situation with anxiety, doubt, or decision paralysis. Another might, find it a curiosity or something like that. So this, essentially what I'm getting at is that the diversity of responses and the diversity of sources of uncertainty tolerance are important to capture if you are to measure uncertainty tolerance in individuals in a holistic manner. Next slide, please. And this is the model again, and it's just basically reiterating what I've said. Different source of uncertainty that is moderated by an individual's characteristics or the context. There's different responses to uncertainty of different types. Doesn't matter. Next slide. So what we did was to create a new measure of uncertainty tolerance. We looked at Hillen et al.'s 22 measures of uncertainty, and we identified what sources and responses to uncertainty tolerance the physician's reaction to uncertainty scale, I mentioned that earlier, captures, and identified what elements, what sources, and what responses to uncertainty were missing from that scale. We then identified every source and response to uncertainty tapped in the other measures, and then those that were missing in the physician's reaction to uncertainty scale, we added items from the other measures to it, such that we captured every single source and every single response to uncertainty outlined by the Hillen paper. We then, with clinical colleagues, adapted the items so they fit the emergency medicine context, and then we felt as though we had a decent measure of uncertainty tolerance, at least for measuring trait uncertainty tolerance. As Emily's mentioned, there is a tension in the literature between some people believe that, you can, it's always online, it's always, it depends on the context entirely, but obviously we treated it as a trait in this study. Next slide, please. So of the patient data we extracted, so this is the other end of the data collection, we extracted things like ASA grades or comorbidities, news scores, arrival modes, complexity, and key demographics. And importantly, we extracted the outcomes that we cared about. So that is things like whether a test or treatment was ordered for that patient by that doctor. But we also, using this slide, this algorithm here, we developed a strategy for estimating how expensive a given episode was. So therefore, we could compare between doctors the average cost of a patient episode adjusted for all the different elements that may confound how expensive an episode is. So a patient's comorbidity status and so on. Next slide, please. And then again, please. Yeah, very quickly. So it's a situation where we had doctor level uncertainty tolerance predicting patient level outcomes. So we used multi-level models to model this. So we use uncertainty tolerance as a predictor of again costs, readmission, reattendance, adjusted for both doctor level and patient level factors. We also ran sort of simple correlations between different doctor factors. So looking at whether uncertainty tolerance was associated with, for instance, resilience and so on. Yeah, next slide, please. So we managed to recruit in the end 41 doctors and match 384 patients worth of data to them. I think it was around 2 to 15 patients per doctor. And these are the percentage of our targets at each site. So yeah, it was right at 80% of the target, which I felt was great. Next slide. And in terms of the uncertainty tolerance measure, we found that in terms of its psychometric properties, it was quite robust. The scores were well distributed, you know, it's spanned the scale. High internal consistency, so each item seemed to be measuring the same construct. And yeah, it was quite a normal distribution of scores across doctors. Next slide, please. And when we correlated the uncertainty tolerance values with these different doctor level factors, we found all sorts of interesting things, such as, again, like seen in the review I mentioned earlier, we found that higher uncertainty tolerance was associated with higher resilience, lower burnout, and higher positively rated work environments. We also saw sort of slight associations with things like increased confidence, more experience, and lower number of clinical hours worked per week. They weren't statistically significant, but because the effects were quite subtle, and ultimately at this level, we only had a sample size of 41 because, of course, there was only 41 doctors. Next slide, please. And these were the associations between the doctor level uncertainty tolerance and patient level outcomes. So just to give an example, so the first row we see any test ordered in that episode, model 4 being the model that's most adjusted for different factors. And as we see, the UT estimate is 0.74, which means that a 1 increase in uncertainty tolerance score meant a 1 minus 0.74, i.e. a 26% reduction in the odds of a test being ordered by that doctor. A 2-point increase in UT would be 0.74 times 0.74, and so on. But as you can see by the p-value column, unfortunately, and next slide, please. None of our associations were in fact significant in this. So while we found the point estimates found that there was sort of a 25% reduction in the odds of a test or treatment being ordered by per 1 increase in UT by doctors, they were all non-significant. So you could argue that there's nothing here, or you could argue that simply our sample size wasn't large enough to detect these sort of subtle effects. I thought it was also interesting that higher UT, the point estimates were actually associated with lower rates of reattendance and readmission. So the idea that perhaps higher uncertainty tolerance was associated with worse patient outcomes wasn't supported, and in fact it was the opposite direction. Higher uncertainty tolerance was actually associated with better patient outcomes. One reason for that perhaps may be that high uncertainty tolerance doctors you know, have more, like, tell their patients not to turn up again, and provide more sort of certain advice to patients. Maybe perhaps lower uncertainty doctors are more ambiguous in their advice to patients, or say come back if you feel this or that. Yeah, next slide, please. Yeah, so just to conclude, ultimately, uncertainty tolerance in our study was associated with positive factors such as higher doctor well-being, though of course it's a correlation. We need a randomized control really to assess causality of that. Increased uncertainty tolerance predicted lower resource use, but again, the associations were non-significant. Whether that's because there doesn't exist an association in reality, unlikely, I would suggest, or just low statistical power for small effect sizes, not sure. The study would need to be replicated and then meta-analyzed perhaps. We found no evidence of associated uncertainty tolerance associated patient harm, again from perhaps risky decision making, which is good. And we also found, of course, that the measure we developed, quite promising. It showed quite good psychometric properties. More validation work is needed there, of course. Next slide, please. And then everything, you know, has limitations. So again, we didn't manage to achieve our full sample size, which of course caused low power and so on. Uncertainty tolerance scores in our study might not be stable within person. I've talked about trait and state. We used uncertainty tolerance as a trait. This study took place during the COVID-19 pandemic, which of course could have affected not only whether who arrived in the emergency department, but also the decision-making of doctors. They might not want patients to come in more often, or so on. Our treatment episode cost algorithm wasn't perfect. For instance, we averaged over different doses, routes of administration, brands of medications, and so on. So that wasn't perfect. And of course, with a correlational study, again, you can't interpret anything causally. We need a trial or to draw DAGs and so on. But yeah, that was our quantitative study looking at uncertainty tolerance in the emergency medicine context, and I'll pass it over to Emily again. Thank you.
Thank you, Luke. And again, sorry for the jumping around. I'm going to attempt to wrap this up in the next 4 or 5 minutes. And so this is just focusing on what we can do about all this, what interventions our research is pointing to. So just to quickly say, the scope and review that I mentioned at the start did also look at any kind of intervention, management strategy or tool that was intended to influence a doctor's experience and or a patient's experience of uncertainty in the emergency department. And basically 0 measured uncertainty tolerance. So there was one protocol that looked at kind of altering responses to uncertainty more generally. It was a protocol for an online teaching course to improve doctors' communication of diagnostic uncertainty. But other than that, it was very much kind of how do we reduce uncertainty? And it measured like the level of uncertainty rather than the level of uncertainty tolerance, if that makes sense. So basically, we're kind of starting from a bit of a blank canvas. So despite growing recognition of the importance of uncertainty tolerance and all the things that Luke's just said, there is still a massive lack of evidence about which intervention functions are most effective. So to address this, I kind of wrapped my PhD up with an electronic Delphi survey. So this involved 23 ED doctors with at least 12 months experience. They went through 2 rounds of rating 55 evidence-informed statements about possible intervention functions and clinical focuses of uncertainty tolerance interventions. So it's a consensus building exercise. And basically we define consensus as at least 75% agreement on an intervention being important. And then we qualitatively analysed the free text responses around the rationales for their ratings. So this picture on the right here is just an example of what they saw between rounds. So if a statement for an intervention function or for a clinical focus, so this example is headache. If it didn't achieve consensus in the first round, we sent it back round for another round, and they could see other experts, what they had said about why they'd given it a rating. They could see their previous rating and reflect on it and re-rate it. So that was about building consensus for the kind of final recommendations of my thesis. So in terms of the areas of clinical focus, there were several that they rated that got consensus as being important for uncertainty tolerance interventions to look at, and they're similar to ones that Luke mentioned before. So chest pain, abdominal pain, headache, syncope, breathlessness, all received consensus as being important. But really importantly, kind of across the board, they considered designing uncertainty tolerance interventions with a specific clinical presentation inappropriate. So that's what a lot of the previous research in my scope and review had tried to do. So instead, they rated all the clinical focuses equally, and then they used the free text comments to explain that all patients presenting to the ED posed some level of uncertainty that required tolerance, and we should be advocating for interventions that enhance uncertainty tolerance as more of a psychological construct, generally in doctors, influencing responses to all uncertain decision making. So this table just summarises the main rationales for why they prioritised certain interventions. So I won't go into this, but just for example, they didn't rate sepsis as high for this because they thought it would conflict too much with the Think Sepsis campaign, whereas chest pain kind of aligned with the existing interventions and tools from the Royal College of Emergency Medicine that they were already familiar with. So I won't go into all of this, but just to say that they rated the kind of intervention functions that had come out from my thesis, and the highest kind of rated ones were around embedding uncertainty tolerance in education and training, and kind of flagging that it was an inevitable component of emergency medicine, and redesigning the kind of curriculum and training around that. There was also high priorities around supporting shared decision making and considering patients' tolerance of uncertainty and fostering supportive team environments, which is no surprise. So just to conclude on some policy implications, and then I'll stop. So I now work in the civil service, and I'm sure you're all familiar with the government's missions from sickness to prevention, hospital to community, that kind of thing, moving the dial a little bit more towards community and primary care. A lot of the conversations that I have at work now are around doing this as a way to reduce waiting lists in hospital. And I am just a little bit conscious that without adequate funding for kind of more senior people in the community and in primary care, that they won't be able to hold the risk and it will actually increase waiting lists. So that is one potential policy implication of this, and something that I flag quite a lot at work. And then I think it's been mentioned in the chat already, but the NHS workforce plan, part of the 10-year health plan, the impact of emotional exhaustion on low retention rates in emergency medicine is really well documented. And as Luke's study showed, uncertainty tolerance does correlate with emotional exhaustion and burnout. So this kind of this uncertainty tolerance interventions and this kind of area of research should be a consideration for the Department of Health and Social Care, NHS England, and the Royal College of Emergency Medicine as a mechanism to reduce burnout and consequently improve retention. I'm going to stop sharing there because I'm sick of these slides. But thank you very much for listening. And happy to take any questions. I'm aware I've given 4 minutes, so I can give my email. Happy for that to be shared.
Thank you, Emily and Luke. It's always difficult, isn't it, to get the timing right when it's a joint presentation, but it was so important to hear everything you had to say, and such a wonderful presentation from you both. So thank you for the detail and everything. There's lots of claps, as you can see.